All right, so the first two techniques that we're gonna go over, and you all gonna practice, is the craniovertebral subcranial distraction with C2 stabilization. That's on page 410. And occipital distraction manipulation. That's on page 411. So when we're talking about distraction, typically we're talking about what type of accessory motion? Joint play, typically. And so since we're talking about distraction and a joint play, what movements are going to be typically improved? All movements. So all movements, so distraction is necessary typically for all movements. Distraction helps to improve all movements. So these techniques will help improve all movements at the subcranial spine. So since these techniques will help to improve all movements at the subcranial spine, guess what I'm gonna have to do? I'm gonna have to come back and show you some specific techniques for specific movements at the subcranial spine once we finish with this. Okay, so the first one, craniovertebral distraction with C2 stabilization. So I know that I'm gonna have to stabilize C2, right? So in the book, the therapist is doing it with his left hand. So I'm gonna do it with my left hand. All right, so I'm gonna get in and stabilize C2 with my thumb, web space, and index finger. So come in. So I've gone over this several times. I start by locating the mastoid process, and I drop inferior medial to that a finger's width. Then I know I'm on the atlas. Then I drop inferior medial another finger width. Then I know I'm on the atlas. Feel that?
It hurts.
It hurts. It's tender. So now I'm stabilizing her atlas. I'm gonna come in with my right hand and get up underneath her occipital lobe and underneath her occipital lobe. So actually, I'm gonna try to capture C1 because I'm distracting away from C2. All right, so I'm gonna try to capture C1. All right, now I'm gonna place my chest or shoulder, anterior shoulder, just on her forehead gently. I'm gonna maintain her to flexion, and now I'm distracting with my right hand. Do you feel that?
Mm-hmm.
So I'm providing a cephalic force with my right hand. And it doesn't take a whole lot to get that. Okay. So this is what's happening. This hand is stabilizing C2. I'm getting in with my right hand, coming in. I can capture C1 or the occiput, either or, and distract away in a cephalic manner towards me. So I'm moving her towards me like this. And this hand is stabilizing C2. Okay? So you kind of get in there and localize your anatomical structures, stabilize C2, and bring your index finger, web space, thumb of your right hand, get in on C1 or occiput, and distract away from C2. Okay? So that's craniovertebral distraction. All right? So occipital distraction manipulation. So now, with occipital distraction, I'm gonna be facing the person like so. So the side that I'm gonna actually be on with this, I'm gonna put my legs so that I can do a lunge, so that I can lunge into it and use my body. So what I'm gonna do, I'm gonna rotate. I can side bend her towards me, kind of rotate her away. Okay, so kind of rotate away from me, and then let me check the hand placement. So he's cradled like this, and what I'm gonna do, I feel comfortable with lifting her and I'm gonna let her head relax on my forearm. I'm gonna kind of modify what he does. So, because I feel like I have better control. So you see how her head is on my forearm. And now I have her rotated away, and I'm gonna slightly side bend her towards me. And so my index finger is gonna come and localize. What's that in Ocean? Is it C1?
Right on the mastoid.
Okay, right on the mastoid. So I'm on the mastoid. So my thumb is on the mastoid, and my line of force, you see my forearm? My line of force is gonna be in my forearm, and I can add more rotation to the right and side bending to the left with that if I have to, okay?
You can side glide, distract a little bit if you're not able to get it locked out.
Mm-hmm. So the rotation locks out the mid-cervical spine. All right. So if you come in and look, again, my index finger web space is on her left mastoid process. I have her rotated right. I can rotate more to the right as I perform the distraction to lock her more out at the mid-cervical spine as I perform that distraction. And I can side glide her more towards me as well to get a greater distraction. Everybody see that? Okay. So I felt like I had better control with letting her head rest on my forearm. Let me see my control without the head resting on my forearm. I still could achieve it that way. Any pain and discomfort with that?
A little.
A little. It's a sensitive area. So the subcranial spine is a sensitive area. I could do it without her head resting on my forearm, but I just feel like I have better control with her head resting on my forearm. So that's the occipital atlantal distraction manipulation. All right. So the next technique is craniovertebral subcranial side bending isometric manipulation and supine. So this is a technique specifically designed, the purpose of this technique is to improve subcranial side bending. It could be side bending right or side bending left. I'm gonna start out showing you the technique to improve side bending right. So make sure you know the rationale behind it, and I'm about to go through it. So this is what I'm gonna do. I'm gonna come in with this, with my left hand, locate her mastoids, atlas, and drop a little bit medial, inferior medial. I know I'm now, what I'm doing now, I'm blocking her axis, C2. So I'm preventing C2 from moving with my left hand. So I'm gonna bring her into some side bending right, subcranial side bending right. And with my middle finger just above her ear, I'm gonna apply some pressure and ask her to hold this position. So hold this position, don't let me move you. So she's holding the position into side bending right. I'm blocking the axis. So the atlas is gliding to the right with this isometric technique. All right. So she's trying to maintain subcranial side bending right. There's an isometric, she's holding an isometric contraction to the right. Which way is the atlas attempting to glide? To the right. Remember that atlas follows the head. So this technique is to improve side bending, subcranial side bending right. When you do the isometric contraction, having the person to hold right subcranial side bending. Does that make sense? Okay. So now, I'm gonna add another layer to this. Could this technique be used to improve subcranial rotation? Rotation of which side? To the left, because the atlas has to be able to slide to the right with rotation to the left. You may want to write that down in your book. Can also improve rotation to the left if working on side bending to the right. Okay. Now I'm going to switch my hand placement. All right. I'm going to switch my hand placement. I'm going to use my right hand now to stabilize C2. I don't want C2 to move. Why am I blocking C2 with this isometric technique? What do you say? Say again. Because I'm what? Yeah, because I want C1 to move on C2, right? I want it to be able to glide. I want it to be able to move with this technique. So now I'm blocking C2. I'm gonna come put my index finger just above the ear on the left side. I'm gonna bias her into some left side bending. Subcranial, left subcranial side bending. Hold this position. She's holding this position. As she's holding this position, which way is the atlas attempting to slide? To the left. Because she's holding left side bending. So that means she's trying to maintain left subcranial side bending. So since she's trying to maintain left subcranial side bending, the atlas is trying to slide to the left. All right. Could this also improve subcranial rotation?
Yes.
To what side? To the right, because the atlas has to be able to glide or slide to the left. So make sure you write this down, because students like to say, well, Olsen goes over these techniques, but Olsen doesn't tell us the purpose of the techniques. So I'm giving you the purpose of the technique. So far I've given you the purpose of every technique, right? You have the purpose of every technique so far, right? Good. Make sure you write that down, all right? Because you're going to be given an impairment in the practical, and you're going to know which one of these techniques you can do for whatever impairment that you're given, okay? So now you can use this one for limitation with subcranial side bending or subcranial rotation, right? You just got to be able to justify it and know how to verbalize it. All right. Now next we got the lateral press of the atlas. So this is what I like to do with the lateral press of the atlas. Olsen makes it simple though. He makes it very simple, which is good. He just has the person lying down. He comes here, put his hand right here, and his index finger contacts, drops off of the mastoid process down our finger width, and he contacts the atlas. And you see my line of force? Right now, I'm doing a lateral press to the right. So I'm pressing the atlas, which is C1, to the right. What does this improve? What is this necessary for? Side bending to the right. Which rotation is it necessary for? Rotation to the left. So it improves side bending to the right and rotation to the left. And now this can be an uncomfortable technique. How do you feel? Okay. All right. So I'm just pressing it to the right. Another thing I can do, I can get her up underneath my arm, like so. See how she's resting on my forearm? Everybody see this? Her head is just resting on my forearm. I can come right here to the atlas and press it to the right, and I can add subcranial side bending to the right with that if I wanted to, with my forearm, like so. And notice my line of force is in line with my forearm. When you go back and watch the video, you'll see my line of force being in line with my forearm, straight to the right, okay? And I would do the same thing if I were to go to the left side. I will come right here like so, put her head on my forearm. The Olsen just shows his arm with the person just lying down, which is fine. I put the arm on my forearm, right index finger coming, contacting the lateral aspect of the atlas on the right side, and I can push it to the left. I can mobilize the atlas to the left and introduce a little bit more side bending if I wanted to. But this is enough right here. Notice my line of force is going which way? Yep, align with my forearm to the left. So if I glide the atlas to the left, that would improve subcranial side bending to the left and subcranial rotation to the right. This is National Physical Therapy Exam content. Make sure you know that. Now you know a manual technique to help with that. You get that patient who's just really stoved up from a motor vehicle accident, they go, oh man, this is as far as I could turn. This is as far as I can go. Then you know, oh man, you only got 15 degrees of rotation. That's soft tissues involvement. You address soft tissues. Then you address subcranial spine techniques, and likely they're gonna have improvements with rotation over time. You know, be gentle, grade yourself. You always grading yourself how forceful you are with techniques.
You can see on the spine here, it sticks out really far, okay? So the way you're gonna find that, you try to find it on yourself and then go find your patient. You know where your mastoid is, right? If you come anterior to your mastoid, but just behind your mandible, your jaw, it's kind of between the jaw and the mastoid, there's a little groove right there, and that firm thing that you feel is actually the transverse process of C1. So that's where you're going to get your hand to apply this force. You feel out that there's a lot of muscle attachment right here. It's kind of a tender area, okay? But that's where you're going to find it, okay? Any question? If you have any problems finding it, let us know. We'll be around.
And now we have to go with techniques that will improve forward bending or forward nodding and backwards nodding in the subcranial spines, because you can be given any of those limitations. So the next technique is called OA unilateral nod. Now, the OA unilateral nod, it can be also done bilaterally as well. But we're gonna focus on unilateral to start out. And so this is one, I can do it sitting down, or I can do it standing. I'm gonna sit down, okay? So now, I'm gonna use my left hand. I'm gonna use my thumb and my middle finger to contact the transverse processes, lateral masses of the atlas, okay? Mastoid, I'm on it, atlas, okay? So now, I have the atlas block. So what am I going to be moving on the atlas? The occipital condyle. So now I'm going to take my hand, and if I want to focus on the left side, so say I want to focus on the left side, I'm going to move her in a nod, a forward nod towards the left side. So you see that her chin is moving towards her left chest. And so what's happening, I'm producing a posterior glide of the left occipital condyle on the atlas. Does that make sense, everyone? Can you visualize that? All right. I can do the same thing if I want to focus on the right side. So now I can bias her towards the right side. So I'm blocking both aspects of the atlas. So I'm blocking both transverse processes of the atlas, lateral masses of the atlas. And now I'm moving her and producing, mobilizing occipital condyle, doing a posterior glide on the right side, being necessary for forward bending. Now it says OA unilateral nod, but remember, you can do it bilaterally as well. So I can go straight down. And now both are being mobilized. Both occipital condyles are being mobilized posteriorly on the atlas on C1. So CO on C1, posterior glides to improve for nod. Okay. So now, remember our deviations. So typically with for nod, if I do for nod and I deviate to the left with for nod, if I deviate to the left with for nod, right? Typically it's because the opposite side is not gliding posteriorly. All right. So say if I deviate to the left with backwards nodding or backwards bending at the subcranial spine, typically the deviation is going to be on the same side. So remember that as a rule of thumb as well. I know we went through the spiel on the chart that we did and went over the first day, but that's typically a rule of thumb that you can expect. All right, so that's the OA unilateral nod. Now, the next one, you would hit it down for me, Dr. McClure. Now this one I use a lot in the clinic, the OA unilateral nod. I use that one a lot. So you can leave it right there. So next is the occiput atlas isometric backward bending manipulation. So make sure you put a star by the next one. You need to know that one for the practical, and you need to know this one as well. So this one right here, your patient is gonna nod the head back on the pads of the fingers. So this is going to result in a backward slide of the atlas on the occiput. So now my fingers are going to be on the occiput, like so. You got that? Okay. And now what I'm going to do is ask the patient to basically push into my fingers. All right, and relax. And push it to my fingers again. Okay, and relax. So now, as she's pushing into my fingers, her occipital condyles are moving anteriorly. They're moving anteriorly. So, which is what's required for backwards nodding. Okay, so push it to my fingers again. All right, and relax. Which way is the atlas moving?
Posteriorly.
It's moving posteriorly. So the atlas is moving posteriorly. Okay, next technique, I'm gonna lower you down some. It's a beneficial technique to improve AA rotation, and you can work on improving AA rotation in either direction, to the right or to the left. Scoot down for me. So the side that I'm going to work on improving AA rotation towards is the side that I'm going to stand on. All right, the side that I'm going to work on improving AA rotation towards is the side that I'm going to stand on. Okay.
Stanley Ferris says you should be a loving therapist. Bring your patient towards you.
Yes.
That's how I remember.
So I'm gonna come right here like so. Okay. Now you may want to get this from the posterior aspect as well. So my patient's right here. She's in a neutral position. I'm gonna take my thumb. I'm gonna have my entire hand like contact in the posterior aspect of her cervical spine. But with my right thumb, I wanted to contact the lateral mass of the axis C2. C1, C2. So it is on C2 like so. Okay. So my thumb is blocking C2. It is blocking the axis. all right? And so my hand is just resting on her shoulder like this, all right? Now I'm gonna engage her like so, okay? All right? I'm gonna slightly forward bend her and then rotate her. So I'm forward bending her. So what's happening with the forward bending, now I'm focusing on the right side, being able to glide anteriorly, how it should when performing rotation to the left. Because I bias her in forward bending to focus on that. All right. She's kind of, I did this on her test trial and she was kind of restricted. She asked me to come back and do it. So now I can just do some gentle oscillation at her end range if I wanted to. And I can back up off of that and ease off of that. Okay. If I incorporated backwards bending, then the side of the facets on the same side would be the focus of the intervention. So I can do that. I can come right here, engage her, go into some backwards bending, and rotate her towards me. Okay. All right. And so with biasing her in backwards bending, I will be focusing on the same side of the rotating direction. Okay. So, but all in all, that would be improving rotation to the left. I can go do the same thing for right. All right, and like so. Now, I'm going to focus on improving AA rotation to the right side because I'm on her right side. So the first time I focus on improving AA rotation to the left, right? So now, again, so on her right side, I'm gonna find her axis. And now my thumb is blocking her axis. All right. So I engage. I'm gonna bias her in forward bending, right? And then rotate her towards me. That's it right there. You feel that? Mm-hmm. So I can back up off that. I can do some oscillation. And notice how the rest of my hand is just resting on her. I'm not doing anything with it, I'm just resting. All right, I'm gonna back up off that, bias her into some backwards bending, and then do the same thing. Now I'm focusing on same side. Okay, and that's it. Good beneficial technique to improve AA rotation. The axis is being blocked, so now we have the atlas moving on the axis. Okay. Any questions about that one?
I have a question.
Yes.
In the forward nod, you're working on the opposite side, and in the backward nod, it's the same side.
Right. That's right.
At least that's what you're emphasizing.
That's what we're emphasizing. Yeah.
So you get a little bit more stress on the back area.
So that's the emphasis. So just biasing them and forward nodding places a little bit more emphasis on the opposite side. Biasing them and backwards bending places just a little bit more emphasis on the same side. So just remember that. No, don't try to rocket science it. Okay. All right.
Okay, so that's a technique that's really, really effective. If you've got somebody who's lacking a lot of AA rotation, it's really effective at gaining. Now think about a lot of these patients who come to see you. They may be trauma patients who had a car accident or something. And you ever seen a patient who's had whiplash? What do they look like when they come to you? right? They're really tight and they're tense, and as they relax, you gain motion, right? They can't go through motion. So think about, you got this patient who's all tensed up and guarded, and their cervical rotation is only like 20, 30 degrees, okay? And you do the vertebral artery and nothing, it doesn't show anything. But man, now you've done these techniques, you've got them relaxed, and you're getting them through 60 degrees of rotation. And now they're starting to complain to you about some of those symptoms that you guys talked about today in your presentation. They weren't initially, but now they're complaining of a little bit of dizziness, or they're complaining of some nystagmus and stuff like that. It may be that now they have enough motion that they're compromising the arteries, where they couldn't rotate enough to begin with. So they start developing those symptoms, you may need to recheck some of those tests, like your vertebral artery, okay, in particular. All right, because now your patient may have enough motion to actually compress and occlude the artery, where they didn't when they were super guarded. So just keep that in mind, okay? Don't assume that because they didn't have any symptoms when you checked them when they were like at 20, 30 degrees, if they start having symptoms later on as they gain motion, it may be worth rechecking, okay?
Okay, so the next technique that we're gonna learn and practice is the facet down slide technique, or sometimes we would say down glide technique. So slide and glide used interchangeably. So the facet down glide technique, the facets slide downward when someone is performing cervical side bending. So for example, when I cervical side bend to the right, my facets have to down glide to the right. On the left, my facets have to up glide, okay? And you go back to intro to ortho and look at the orthokinematics of the cervical spine and look at what the down glide entails, which is an inferior posterior movement, and up glide is a superior anterior movement, okay? So make sure you know the intricacies of the down glide and up glide. So, but when I side bend right, I have to down glide on the right, up glide on the left of the mid-cervical spine. If I side bend to the left, I have to be able to down glide on the left, and I also have to be able to up glide on the right in the mid-cervical spine. I have to be able to down glide at each segment, and I have to be able to up glide at each segment to perform the side bending movements. So with that being said, if I'm limited in side bending right, it could be that it could be a down glide limitation on the right, or a down glide restriction on the right, or it could be an up glide restriction on the left. Does that make sense? Okay. Now, it could be the entire segment, it could be C2 through C7, or it could be just at a particular segment, okay? You have to know how to assess it and treat it. This is a technique that you can use to assess, and it's also a technique you can use to treat, okay? So you all are gonna be feeling that when you all work on each other. So with Victoria, I'm gonna start with, since we have the camera right here, you can leave it over here. I'll start with assessing her down glides. So I'm gonna be assessing the down glides to both, on both sides, okay? All right? I'm gonna advise her to some slight flexion. I'm gonna have her head to rest on my stomach. So you let the person's head rest on your stomach. So I got her head, my stomach has her. She's not going anywhere. I'm gonna take the lateral aspect. I always gotta go back to the anatomical position. So I'm gonna take the lateral aspect of my index fingers and my web space, and they're gonna go down to C7. I'm gonna be all the way down here starting at C7, and I'm gonna work my way up segmentally. So I'm gonna see how C7 is down glided on T1, how C6 is down glided on C7, how C5 is down glided on C6, and thus forth. You see? So I'm gonna start with the left, and I'm comparing each side as well. So right now I'm doing C7 on T1, and then I work my way up. C6 on C7. C5 on C6. C5 on C6. Why do I feel like you get more going to the down line? Huh?
You on my head.
Yeah. Okay. Is it your hair restricting it? Okay, yeah, that's what it was. Good feedback. All right. C4 on C5. See, I felt restricted, but I was on her hair. I'm like, that's, so it's pretty much, she has some good down glides. They feel free. I don't feel anything restricting me. Remember, how do we grade, how do we categorize or describe our motions? Smooth. Any crepitus. All right. Now I'm up here now. So I work my way all the way up to C1 on C2. But mid-cervical spine is referred to as C2 through C7, all right? Her down glides felt good. I didn't feel any type of restriction. They felt smooth. They felt symmetrical on each side. I didn't feel any abnormalities as far as one being more hypomobile than the other. No crepitus. I didn't feel any type of crepitus. So her assessment, I would check that and move on. So that was the down glides. Okay, very, very easy. So let's go back through this again. So again, I'm gonna move her hair like that. All right, come back down. So if I'm assessing the down glide to the left of C7 on T1, my hand is moving towards her right hip. So I'm moving at a diagonal. So my force is a diagonal towards her right hip. You see, like so, to produce a down glide. If I'm doing the right side, my force is moving towards her left hip. So it's like this. On the right side, it's like this. On the left side, it's like this as I work my way up. So you can say, in orientation to the body, you can say, in a sense, inferior medial, an inferior medial type of movement if we reference the body in anatomical position. All right, how that feel? Okay. The up glide, or sometimes referred to as fourth glide. Okay. So now I'm gonna do the same process, a similar type process, but now I'm gonna get her head, kind of bias it on my stomach. I'm gonna kind of rotate her to the right with this one. So I'm gonna contact her, come down middle trapezius, get a contact with C7 on T1, and my force is gonna be a superior force, almost like a superior medial force. So this is my force right here, like so, to assess the up glide. All right. So up gliding on the right is required for what? Okay. So up gliding on the left would be required for what? Okay, yeah. So I'm assessing her up glides on the left now, which would be required for side bend and right. So working my way up. Now this is one where I typically don't, I come back and assess the other side, but I don't alternate like how I do with the down glides because I got the person's thighs and some rotation, so I'm not going to be doing that over and over. Prepare. I can work my way back down. Now I'm going to compare. So now I'm going to perform the up glides on her right side. Again, this is my force. My force is actually mimicking the orthokinematics. Because remember, superior, anterior with the up glide. And just going through the motion and then backing off of it. I wish I had somebody with I should have chose somebody with some restrictions. Ventura has good cervical mobility. So her up glide's good, you got restrictions. See, like, Gabby like you do. See? Okay, so that's the up glide. And you can read through the descriptions too to help you out.